is Jim Smith. We're just adjusting the slides. And just a little bit about me, because I've been told I'm supposed to make sure you hear the qualifications of the speakers. I have one caution for you. In the New York Physical Therapy Association, I'm on the nominating committee. So I look forward to meeting those folks who I don't know and talking about ways you may be able to help us advance physical therapy and the profession here in New York. I'm also have been very, very active in the Academy of Acute Care Physical Therapy, including past president of the Academy. Also, I'm on the nominating committee right now for the Academy of Acute Care Physical Therapy. So if you're a member of that, I'll pull you in two directions to keep you involved. And as Brittany said, I'm also the principal investigator for a team that is developing a clinical practice guideline on post-intensive care syndrome. And within an hour, you're going to have a very good understanding of what that is and why we think it's so important. This is my team. I'm very excited that we have representation from American Thoracic Society, the Society of Critical Care Medicine, American Respiratory Therapy Association, American Occupational Therapy Association, and others in this process because of their investment in the management of people who have this complex problem that I'm now post-intensive care syndrome. So, I'm going to get started with this. I want to start by inviting questions. When you have questions, please ask them. I don't have a real defined or structured path through this presentation, so it won't trust me if you have questions. I do have the disclosure that I have no financial benefits or interest from this work. However, I am funded by the American Physical Therapy Association and the Academy of Acute Care Physical Therapy for the development of a clinical practice guideline on post-intensive care syndrome. So what I'd like to start with is have you consider this patient who's coming to your clinic. She's a 37-year-old female. Can everyone hear me okay? And they're hearing me okay at home? All right. In your pajamas. 37-year-old patient with plantar fasciitis, and she's no longer able to run as she was used to. She's been doing half marathons and even a few marathons. She's been averaging recently 25, or had prior average of 25 to 40 miles a week, but she had some medical complications, unable to return to running, really due to the plantar fasciitis, but there's other aches and pains. Decrease in endurance, recent bout of pneumonia. She's now been referred to your clinic. Great, we can deal with this because we have a clinical practice guideline on plantar fasciitis. First, there's a theme here. My students started to see I like clinical practice guidelines. They're very informative. And when I think about this 37-year-old patient who's a runner, this is where my answers are. I can go to the guideline, and it's going to inform me about her, about the examination that I should apply to this patient, that I should be using outcome measures and gather information about her abilities, and as I do that, start to find out a little bit more. She has a history of endometritis and a history of an autoimmune thyroid disease. And a year ago, she had a high-risk pregnancy that resulted in a cesarean birth. It was complicated by syndrome called hemolysis, elevated liver enzymes, and low platelet count. That led to a medical crash following the delivery. It landed her in the intensive care unit, and she was in the intensive care unit for about 5 days. Since then, you start finding out on the history that she has to make lists to remember things. She reports upper respiratory infections, episodes of pneumonia, and she's extraordinarily fatigued. Plantar fascia pain has been a concern, and that's actually what triggered the referral to your clinic. But she also has a few aches and pains that have been a barrier every time she tries to return to running. Did this picture change a little bit from a 37-year-old running 25 to 40 miles a week with plantar fasciitis with this information? So what's going on here? This 37 years old is really surprised when you bump into these types of problems and you find out that running may not be the greatest challenge. Right now, getting through some of her days is a big challenge. I propose that what we're seeing here is post-intensive care syndrome. This is a term that was coined in 2012 to describe the constellation of new or worsening problems involving physical problems, involving mental problems, and involving cognitive abilities among individuals who have experienced critical illness at times for as short as 48 hours. Not a specific pathology, rather it's a syndrome that is following the episode of critical illness. And we need to know about this because we admit about 5.7 million people each year into intensive care units in this country. Our survival rates have gone up. In some ICUs, the survival rates are as high as 90%. That means we're discussing more than 4 million people a year are likely going to present with some of the problems in this syndrome called post-intensive care syndrome. I was here on Saturday. What was the presentation? On Saturday, we had a wonderful presentation on campus around concussion. And we thought the numbers were pretty impressive because there were 2 to 2.5 million concussions occurring in this country every year. That's a lot. Doubling that number when we look at post-intensive care syndrome. So, what's involved with post-intensive care syndrome? It's really problems in 3 categories. I'd like to cover them by category. The mental health impairments, problems that persist appear to be anxiety, depression, and post-traumatic stress disorder. We're really recognizing that people who are in the intensive care unit have high rates of post-traumatic stress disorder, primarily related to the hallucinations that accompany the delirium during the time in the intensive care unit. It's not part of today's presentation, but the Society of Critical Care Medicine has developed a clinical practice guideline on pain, agitation, and delirium in the ICU. And the treatment for this delirium, that is the source of so many problems, is early rehabilitation. We need to reduce the level of sedation, which is a system-wide change in how we manage those patients. And we need to be involved in getting those patients in the intensive care unit upright and engaged in physical activity. That's a whole other area of interest that we're not going to cover today, but I wanted to advocate that the Society of Critical Care Medicine's guidelines are our best friends for this. And they are there are members of the society, physicians and physical therapists, who are promoting this and trying to advance it. There's cognitive impairments. Survivors of critical illness have problems such as disrupted executive functions, memory problems, as we heard in the case of the 37-year-old woman that started this presentation. Changes in attention, visual spatial processing disorders, so that, for example, negotiating in environments where they have to see and adjust for other physical barriers or other people moving, have trouble with that. Slow mental processing, so that they are processing a lower speed as a likelihood, not an assurance for all patients, but a likelihood for those who have critical illness. And the focus for today is going to be on the physical problems. Those physical problems tend to be in the areas of respiratory functions, neuromuscular functions, and physical functioning, or more in our guide language, the abilities for activity and participation. That's going to be the focus, although at the end of the presentation, we want to go back and consider mental health impairments and cognitive impairments that people are experiencing, because that's going to influence their ability to engage and participate with our physical therapy. A few things to be aware of for people who do experience critical illness. Factors that increase the prevalence of post-intensive care syndrome are sepsis, longer duration of mechanical ventilation, longer duration of delirium, longer time in the intensive care unit, and historically there was concern that neuromuscular junction blockers such as pancuronium and vancuronium were associated with the weakness that we see in post-intensive care syndrome, and that corticosteroids may be associated, and now our understanding is that those are not risk factors for post-intensive. However, we're still trying to reduce the use of those because of the benefits of moving people into activity early in the process of being in the ICU. Let's take a few minutes and look at the physical presentation of people with post-intensive care syndrome. This is the focus of our work over the last year or so, because we're developing a a systematic review of the literature around the physical problems post-intensive care syndrome, and that has been in review with the Journal of Physical Therapy for quite a while. We finally got notice 4 days ago and are making some edits to this and look forward to getting it back into PPJ. So you're getting some of this information ahead of time. What we've done is, from part of our delay in appreciating how severe the problems can be following critical illness, has been that historically we measured survival. A good ICU was one in which people survived. And only in recent years have we started to look at information beyond that, such as quality of life and activity and participation in impairments such as preservation of strength and flexibility. So there was non-homogeneity of the outcomes. There are all kinds of different measures that have been applied because the study designs, the interest in this has really come out of the critical care medicine part of healthcare, and it wasn't something they typically looked at. So it was a little hefty to wade through and get an appreciation for what these physical problems were. So to bring that into focus, we used the International Classification of Functioning. I just have to check. Can people still hear me okay? Right, because you could move. So we're looking at problems with body functions and structures, problems with activities, or problems with participation. And when we look at that, we found there were impairments in pulmonary function. What we're going to see for the next few slides is a graphic. The graphic gives us a representation. We captured information about the trajectory of recovery over the first year following an episode of critical illness. And we were able to get data sometimes at 3 months, sometimes at 6 months, sometimes at 12 months. And for example, we know pulmonary function tests are reduced 6 months out from the episode of critical illness. Muscle strength, all right, muscle strength is markedly reduced. Respiratory, lower extremity, upper extremity, and hand grip strength is reduced 3 months out, 6 months out, and that persists. And that's an interesting consideration because we also know from other studies that did not meet our inclusion criteria that persistence of weakness is a problem 5 years out, and 9 years out, and 10 or more years out for people who have experienced stay in the intensive care unit. Exercise capacity, as measured by a 6-minute walk test, is also reduced. Seeing reductions 3 months out, not surprising after someone's had critical illness, but look at the trajectory of recovery. 6 months and 12 months out, there's almost no trajectory of recovery. It's pretty much consistent across that time that their performance on 6-minute walk test is reduced. Pretty worrisome if I need to go grocery shopping or hiking to a presentation on a campus like this or get in and out of a place of worship. Those are real problems for our patients. And that seems to contribute to some of the other problems we see. Patients aren't getting back to work. More than half of them aren't returning to work a year after an episode of critical illness. And I should clarify, this is a relatively young population. Typically, in our studies, we were seeing average ages in the late 40s to mid-50s for these populations. So we're only looking at, when we looked at return to remunerative employment, we were only looking at those who had been working and desired to return to the workplace. It's hard to do that if your 6-minute walk test performance is reduced. Problems with activities of daily living. Look at that trajectory. It also persisted so that people had problems 3 months out, and that continued to be a problem 12 months out. IADL did better, but the suggestion from the literature is that the ones who had more problems weren't surviving as well, and so we think that conclusion is not as clear because of those who were lost to follow-up studies. So given those problems, what should be part of your examination of those patients? Just curious about that. So the next part, I want to focus on your management of the patient. What will be part of your examination? Well, for the impairments of body functions, pulmonary function tests and measures of respiratory muscle strength are beneficial. If that's not a routine part of your clinic, realize, and we'll talk later in the presentation, that you may want to coordinate with other members of the healthcare team around this. However, this one is in our routine care of patients. Strength. We recommend that your examination should include measures of strength. Manual muscle testing is one way to gather that information. And I also am curious, who's familiar with the MRC, or Medical Research Council, sum score? This is used a lot in the research, and it's used a lot in the research around critical illness. To generate an MRC sum score, you're measuring essentially with a manual muscle test scale, 0 to 5, there's no pluses or minuses, for the motions of shoulder abduction, elbow flexion, wrist extension, 3 upper extremity motions, hip flexion, knee extension, dorsiflexion, or 3 lower extremity motions. Each of those has a potential score of up to 5, so on one side of the body, your potential score is 30. You measure both sides, potential score is 60. So you have basically a range from 0 to 60 for the MRC sum score. Sum that, and in some of the research, not recommending this as a clinical judgment, but in some of the research projects that have looked at this, they've categorized people as having ICU-acquired weakness, when the MRC sum score was less than 48. That's a pretty pronounced decrease in strength. I'm also a fan of handheld dynamometry because of the ceiling effect of manual muscle testing. We tend not to capture the deficiencies in these patients who were, again, like the woman in this case. Last year, she was running marathons and half marathons. This year, she's got plantar fasciitis and apparently a lot of other things going on. And I enjoy using handheld dynamometry because of the normative data. And I can then compare her not to my my measure of her strength, which may be accurate, may have reliability, but doesn't allow me to distinguish compared to other women who are 37 years old. It also is a very informative tool for a trajectory of change, because we're going to talk about interventions for these patients, and if they have a protracted recovery, then it's very helpful to them to be able to see tangible changes in strength. And a change from 4 to 5 doesn't impress the patient, and often a change from 5 to 5 doesn't impress the patient. But when I'm able to say, last month, your strength was 32 from this systematic review and said, what else is there? What would you share? What needs to be addressed in the clinical practice guideline? 2 of the 3 people said, I got home. One of them, actually the person in this case study, got in the door, went up 2 or 3 steps, and collapsed with fatigue and could not get to her bedroom for 2 hours. She's a physical therapist. Her husband's a physical therapist. She could not get up the stairs to her room for 2 hours and is still traumatized by that because her kids saw it. Mom is there, collapsed on the stairs, and did not have the capacity to get there. The other one for a couple hours. So yes, these things are cumulative. When we look at getting in the car, walking up the stairs, it's cumulative. When someone can toilet themselves, but that needs to be followed up with fixing a meal and dressing yourself, that's cumulative, and we need to address that as well. And to me, that I'm going to jump ahead a little bit and talk about energy conservation. One of our strategies should be energy conservation. And energy conservation isn't saying you shouldn't do so much, because we're talking about people our age that have a devastating change in their abilities. We need to help them prioritize where that energy is going to go in the morning and where it's going to go in the afternoon, and which days it can be dedicated to physical therapy, and which days it needs to be dedicated to caring for family members, life and work again. So that becomes really important for this population. Are they hearing me now okay? All right. So in designing a plan of care, one of the things we need to do is look at compensatory approaches. If this decreased aerobic, that's not going to change quickly. What do we have for compensatory strategies, which may include energy conservation, it may include assistive and adaptive devices, and it may include pulling in family and professional resources to allow them to deal with this until we get to restoration. Restoration is really where you're providing the physical therapy interventions that are going to change their capacity so that they can do more and they have greater strength. That also means we've talked about managed transitions of care, and I just want to clarify. Physical therapist who had been a marathon runner, who is our case today, collapsed down the stairs because it was a transition of care that overwhelmed her physical abilities to function. We need to look at these transitions of care, whether it's from hospital to rehab center to home care to outpatient services, with a very deep appreciation of the burdens that are going on with these patients and families, and predict for them what types of resources they need in place so that they're not spending 2 hours on the stairs in front of their children. Coordinate with other members of the healthcare team. We're going to need to rally the troops here for this complex problem, which is involving all parts of our patients' lives. So, what are we going to do about it for interventions? Here's my bad news. Look at this. I'm going to have a couple Cochrane reviews. Here's a Cochrane review on physical rehabilitation for critical illness, myopathy, and neuropathy that concluded there are no published randomized control trials or quasi-randomized control trials that examine, whether physical rehabilitation interventions improve activities of daily living for people with critical illness, polyneuropathy, and critical illness myopathy. Well, that's pretty depressing. Another one, a Cochrane review on exercise rehabilitation following intensive care unit discharge for recovery from critical illness. At this time, we're unable to determine an overall effect of functional exercise capacity or on health-related quality of life of an exercise-based intervention initiated after ICU discharge for survivors of critical illness, 2015. So I'm starting with the bad news. The bad news is we don't have much to offer. Now, these were based on limited evidence, in part because this is a very new appreciation of these problems. Even though it's involving millions of people, This one, for example, involves 6 trials of a very complex patient population. They tend not to be homogeneous groups. They tend to, some have cardiac problems, some have pulmonary problems, some have experienced sepsis. And so it's often hard to categorize this, but what we are appreciating is, for example, one very well-developed study that looked at people with acute respiratory distress syndrome who landed in the intensive care unit. Their respiratory functions had returned to normal after a year, and their 6-minute walk test remained markedly impaired. So this review found 6 studies. Their interventions weren't anything that would have impressed you. For example, one was exercise physiology students who did phone consulting with patients. They met them one time, gave them exercises, did phone follow-up under the guidance of an exercise physiologist. It wasn't physical therapy. It wasn't customized because in research too often we standardize our interventions for that consistency. So I'm not surprised that the results weren't impressive in the data that was available when they did this Cochrane review. Let's go back to what we know about these problems from our ICF model and look at interventions directed at impairments, directed at activity limitations, and directed at participation. And we start to come up with a little more clarity. So in your handout, I did include this study by Major et al. That is a comprehensive and well-developed resource on surviving critical illness. What is next? It's a consensus statement on physical rehabilitation for people who have left the hospital. And I recommend looking at this one. Really, this is directed at times for people who are still somewhat impaired and involved with rehab, all the way to those who are functioning pretty well. So they put a lot of information to a rather concise graphic here for us. What I'd like to do is look at one study that, I'm sorry, I got ahead of myself. What I'd like to do in looking at interventions is also challenge us that I think we don't provide sufficient demands to our patients with exercise interventions. I have that opinion, but I also have some evidence, and here's an example of that was published in Physical Therapy a couple of years ago. And what they did was really when they set out, it was to look at 6-minute walk test performance in people who were discharged from the intensive care unit. So 1 week after discharge, while they were still hospitalized, they measured 6-minute walk test performance. It was decreased. Not a surprise to me, as we've seen with the other literature, it's going to be decreased. But then the other thing they did is they looked at the physical therapy interventions provided to those patients and compared the distance walked in physical therapy with the distance that they were able to walk in a 6-minute walk test as part of this research project. And they covered less than 30% of the distance they were capable of doing on a 6-minute walk test during the physical therapy interventions. And the authors rather politely said, we can't understand why they did that. It clearly can't be due to lack of time to do it. It was a 6-minute walk test. So we need to challenge our patients, and I'm concerned that too often we don't. Here's a great study that is informing what we can do, and this one, Improving Rehabilitation After Critical Illness Through Outpatient Physiotherapy Classes and Nutritional Supplements, and they found that they were able to increase strength, increase aerobic capacity. They did that by individualized exercise programs. So rather than standardizing everything, they customized the program. They did use interval training through 10 stations, 1 minute per station, and rotate. They also used cardiovascular exercises that engaged all major muscle groups, trained them. They train them at intensities at 50 to 70% of the heart rate reserve, and the board breathlessness score of 3 to 4. If we go to the major article, they also recommended that another way of dosing intensity may be to use their 6-minute walk test speed and have them train at least 80% of their 6-minute walk test speed or greater. The goal was to maximize strength, maximize aerobic fitness. So we now are starting to see evidence that with interval training, cardiovascular training, we can maximize strength, maximize fitness. And now my question for you, in our therapeutic exercise prescriptions, we need to identify, we need to have a prescription that has a mode of exercise, intensity of exercise, duration of exercise, and frequency of exercise. Which do you think is most important to progress, to advance for this population if you desire greater strength and greater aerobic fitness? What's that? Intensity. Who else says intensity? A lot of intensity. Anybody for duration? We'll exercise them longer. Some duration. Anybody for frequency? We'll bring them in more often. Well, that was the other thing in that study. I think it was twice a week. They were training them, but they could exercise beyond that. They recommend it was advancing the intensity that was essential to achieving the benefits. They recommend advance the intensity before increasing the duration of the exercise. I think that's important. Too often we're providing an exercise, but we're not getting to what we know is fundamental component of exercise. We need to achieve overload. So back to those fundamentals for the students. That was last year. Right off. Thank you, Dave. Because that was what? First semester, you learned there are specific adaptations to impose demand. You want specificity of training? Back to Kisner and Colby. Simply stated, if muscle performance is to improve, a load that exceeds the metabolic capacity of the muscle must be applied. We've got to continue to increase the intensity. Want to bring up some other considerations for interventions. Well, I peek at the time. And that is, there's a lot more in our bag of tricks. Keep in mind, this is very intimidating to our patients, so we want to be involved with instruction and education for them. For some patients, airway clearance techniques are going to be important, given the respiratory problems that accompany this. We've already talked about compensatory strategies and the use of assistive technology. There may be a lot of benefit from functional training, motor function training, and then we've already looked at the restorative benefits from therapeutic exercise. So, to summarize our physical therapist approach to this, compensatory strategies and energy conservation are valuable early on. When we move to our interventions to restore their abilities, we need to achieve overload. We're going to need to increase the intensity of the training through a combination of both resistance training for strengthening, cardiovascular training for aerobic capacity. We should be adjusting the intensity of the exercises and progression. Well, actually, I've covered that one. And one other thing that I recommend is an exercise diary. Daily diaries are an important part of managing patients in the intensive care unit. And we know that because of the memory problems, they're very effective for the patients. So they're probably going to be familiar with diaries. Use them now, because we're talking about patients who are dealing with a prolonged recovery, and for them to be able to go back and realize where they were a month ago and a week ago is going to benefit them so that they remain engaged in this long course of recovery. A few more things that are important. One is this concept of PICS-F, or PICS family members, because we know that people who are family members of someone who's been in the intensive care unit are experiencing post-traumatic stress disorder, anxiety, and depression. Cumulatively, they are having decreased quality of life. As a family member who's seen someone in the intensive care unit but receiving these services, so they tend to be overwhelmed. Because after they develop these problems as family members, they now are getting someone home who needs much, much more help than they needed before, who's not holding up their end of the household management, and it's going to be important to help them appreciate what's going on with post-intensive care syndrome. So I have some links available in the handout. This one is from Society of Critical Care Medicine. It tells us this is available to educate about post-intensive care syndrome. Family members appreciate what's going on. And then a few other opportunities here. I mentioned earlier, given the complexity, there needs to be coordination of services for our patients because currently this is often fragmented. Physicians don't understand what the PTs are doing. PTs aren't coordinated with the psychotherapist who's managing the post-traumatic stress disorder. So we need to look at strategies for coordinating the services for our patients who are experiencing mental health problems, cognitive impairments. I'm not the expert on that, but I do need to coordinate with psychotherapists, and I'll make a pitch here in particular for neuropsychologists. Those psychologists who've done a residency in neuropsychology have been wonderful resources to me because in addition to being able to clarify what impairments a person has, they also clarify what strengths they have. When I understand their strengths in problem solving or reasoning or executive functions, I can help them with compensatory strategies as they deal with their physical problems. We need to partner with their families, provide the education, engage them in this, validate the problems they're dealing with having a loved one who has PICS. We also need to coordinate with occupational therapists, speech therapists, and respiratory therapists, depending on the types of problems they experience. And we need to coordinate with primary care providers who are not informed about post-intensive care syndrome. Remember, we're talking about 4 million people a year. If that were cancer survivors or stroke survivors, there'd be an appreciation within the healthcare system about typical problems that they're going to encounter. We don't see that yet with PICS, and that's really what our job is, the team developing the clinical practice guideline, is to get the word out there. But this is a new problem. PICS was coined in 2012. The woman who's in the case study here, when I heard the history, I said to her, "Oh, you have post-intensive care syndrome." She said, "No, I don't. No one ever told me that. Wasn't around before," and most people aren't aware of it. So we need to get the word out about this problem that is disrupting activities of daily living, disrupting ability to return to work, and it's doing it to quite a few people. I recommend that we need to do that also because this is a potential referral source. And for those of you who start to encounter this and see some benefits from treating this, you may want to get the word out that your clinic can handle this complex problem. If you're interested in that, just make a pitch that APTA has a Marketing 101 tutorial. If you go to the web page for APTA, it is available to us, and not something I'm going to dive into now, but you can use this as a resource for developing marketing strategies. While you're doing that, there are resources available that I find helpful to educate other members of the healthcare team. Until now, these have always existed within the critical care medicine realm. That's who's familiar with this, but they're not the ones who are treating these patients. They've done their part. They've moved them out from the intensive care unit. So there are resources such as the ICU liberation resources, from Society of Critical Care Medicine, others that are put out by Vanderbilt University, others, and there was an article introducing post-intensive care syndrome to the physical therapy community about 3 years ago in PTJ that I really liked because I wrote it with an old colleague of mine. So I've covered a lot of ground. Now I've got a nice picture up there, but the lighting doesn't let you see it too well. This is boating the Colorado River last summer, a year and a half ago. I spent 17 days boating the Colorado River through the Grand Canyon on a private permit and had my dream trip and can't wait to go back. I'll leave that up there and see what questions you have that I can answer. Yes? As a syndrome, we're going to see the criteria as someone experiencing the cognitive, the mental, or the physical problems. So I would consider someone to have post-intensive, the physical problem with any persisting muscle weakness, with any reduction in aerobic capacity. And once I start to see that, I'll ask about other problems such as PDL, performance. But those, that's as close as we have it right now because I'm going to recommend you anticipate post-intensive care syndrome for anyone who's had a stay in the ICU, because about 80% of them are going to demonstrate some component of PICS. So a typical patient who's having these types of problems is going to transition from the ICU to the hospital, have some time there. That's where we have our first high-impact influence on them. We need to look at how well they're functioning, similar to what Dr. Hickey said earlier. We need to determine, do they have the capacity to get in and out of the house? If they do, is that all they can do? Are they then homebound? So we need to anticipate what types of problems they have. Do you have stairs getting in and out of your house? Do you have someone who can shop for groceries and fix your meals, or are you the person who does that? Do you have a pet that you care for, or other responsibilities? Is the heat on in your home? These are all things that need to be addressed before that person can make the transition. If there are not abilities for that, if that person is the caregiver for another, for example, and they need to be a caregiver when they return, then we need to determine the optimal level of services and placement before they land at home, because home isn't going to give them as much rehabilitation as an inpatient rehab study will. So they may need that in order to make a successful transition to home. And then for the students, you're going to be learning more about what it means when we talk about home care services, because home care services don't require that you be homebound, rather that going out for outpatient services, such as seeing you for physical therapy, isn't a feasible option because they're too exhausted to make it back into the home. So that's another longer answer, because what we know about physical therapists is we start to filter lots of information into the decision making about our recommendation for this position, but we have to look at it at each stage, because should they go to rehab, you really have that same set of questions to answer. Can this person go home? Well, do they need to buy groceries to go home? Are they going to be a caregiver for someone else? And if that is the expectation, then we need to figure out how we're going to get them well enough to be able to perform those or provide sufficient resources for it. Did that clear it up? Yeah. Molly.
Well, I just want to continue to underscore that students all the time have individuals that here
Sounds like a long one. I'm going to put the mic near you.
Relatively functionally independent. And we test them using some of those measures that you mentioned, which show a definite decrease in sustainable function. And we recommend inpatient rehab because they live alone or whatever the case may be. They don't have the ability to get in and out of the house or get to outpatient therapy. And if we don't document that in such a way, a screener will come by, a rehab screener, and say, that person's too high functioning. They don't need to go to inpatient care. So it's really up to us to document that and make the justification, but we have to do it intelligently in using those tests and measures and really providing a thoughtful analysis for why that has to be. Home care is getting tougher and tougher. They will say you must be homebound. And if you're not, they say no dust in New York right now. So I understand where you're coming from the thought
Medicare
process
guidelines.
behind.
The wording in the Medicare guidelines is such that undue effort.
Right. So it's a friction at all different transitional levels of care. But you guys, we can be the heroes in this story because depending on how we document it and make the case, we can get these people the services that they need.
And I also want to caution that the picture I've painted of post-intensive care syndrome is what we are able to describe based on the available literature. There appears to be a number of other problems, such as exhaustion. It's fatigue, similar to what we hear from people who have multiple sclerosis. They hit the wall and are just exhausted. I don't have evidence around that yet. I have that, for example, that was the theme on Thursday night with the stakeholders who were part of my meeting. And a range of other problems, such as pain for some folks, swallowing disorders, sexual and intimacy problems, all pop up in places in the literature, but didn't rise to the threshold that we could fit into the criteria we had for the systematic review. So there's a lot going on challenging these individuals. Other questions? Yes?
Also, the studies you're showing, like, that were vaccines that these groups are also functional to a period of time after illness. Today, in those studies, say that the patients did have some form of therapy or not, or just like anybody's across the board.
Most of them did not address whether or not for people who were listening, she asked about the trajectory of recovery and whether or not intervention had been provided. Rarely was that described in the research that we accessed or the studies that we accessed. The only ones that tended to do that were the ones that were specific intervention protocols for people who had critical illness. And in those cases, as we saw in the two Cochrane reviews, there was not a benefit that was evident. So, no, that's another question we need to answer. But, yes? The question was whether there's a difference for people who are intubated or those who are in the ICU and not intubated. And there was one study in our systematic review in which those who were not intubated but were in the ICU for at least 48 hours had similarly severe problems. And there was one study that didn't meet our criteria that did a similar comparison, and they also had persisting problems. So the longer they're intubated, the more likely they are to have the problems, but you can have those problems without needing to be intubated. Surprised me. Well, thank you very much. I'm going to turn this over to Brittany and the Central District meeting, and I hope you found it informative. Yes. All right.
I don't know how you unlock it.
Oh.